Well, good morning, everybody. As Dr. Newell mentioned, I am a board-certified internal medicine doc and a hospice and palliative care doc. I also have the pleasure of being the chair of Board of Trustees of Delaware Breast Cancer Coalition, and we have put together, as you can tell, a wonderful program for this morning's breast cancer update. I thought that this would be a good topic for today's discussion, and there's a few reasons for that. As much as we would like to cure and fight all cancer as much as possible, I think that the harsh reality remains that sometimes we're not able to cure 100% of cancers, and advanced cancer sometimes can cause a lot of suffering, which is where hospice and palliative care comes in. I have been practicing hospice for about 21 years, and I'm very passionate about hospice and palliative care. And I thought that this would be a good topic for us to talk about briefly today, create some more awareness, have opportunities to answer some questions, because there is still some clarity and some clearing of misconceptions that's needed. So this morning I'm joined by Dan DePietropaolo, my colleague and a hospice fellow hospice care provider who has been practicing hospice for many, many years, just like myself. So with that, can we have the next slide, please? Okay, so today we're gonna talk about what is hospice and how can it help. And I'm going to tag team with Dr. DePietropaolo here, and we're both going to, just talk a little bit about hospice, allow for some Q&A, and hoping for this to be a very interactive session. Next slide, please.
Okay, very nice to be with everybody this morning. And my first slide, hospice versus palliative care. And I think that distinction confuses a lot of people. What is hospice? It's one small part of palliative care. It's the part of palliative care that deals with symptoms at the end of life. So it's for patients with a prognosis of 6 months or less if the disease runs its usual course. When does a disease do that? Hardly ever. Sometimes it doesn't run its usual course. We have patients that live longer, patients that live unexpectedly shorter. We deal with the management of all related discomfort. Could be pain, shortness of breath, nausea, fatigue, anxiety, and any other symptoms from the disease. Well, I've said that hospice is one small part of palliative care. What then is palliative care? It's care that focuses on comfort rather than cure. And it can be for any patient with a chronic disease. And there are a lot of chronic diseases that don't really limit life expectancy very much. Rheumatoid arthritis, multiple sclerosis will cause tremendous pain, and someone will really need palliative care so they can make the best out of every day, but they're certainly not in the 6 month or less category. So palliative care can be part of anybody's care program with a chronic disease, and prognosis is not an issue. Dr. Virani?
Yeah, no, I think this is a very important distinction, Dan, because there is a lot of confusion about what is hospice and what is palliative care. Can we have the next slide, please? So, let's talk a little bit about stigma and misconceptions. What we hear often in the field of hospice is people feel and people think that hospice is where you go to die and when your doctors have given up. And I'd like to talk about that for a little bit. It's actually quite the opposite. It's not where you go to die, and it's not when your doctors have given up. Unfortunately, when we can't cure the diseases to the best of our abilities, be it advanced heart failure, advanced COPD, dementia, and in this case, cancer. When the cancer has reached a point where there is no cure possible, it has spread significantly, and the burden of symptoms is tremendous. When there is no possible cure in sight, that's when a recommendation for hospice and palliative care is made. It's not where you go to die. Hospice and palliative care is a program that can help tremendously to the patient that's suffering and the family and the caregivers that are also struggling, to help manage symptoms, to help them guide through the disease process, provide education, and provide resources in home, in the hospital, in the long-term care facility, wherever that patient might be. And doctors, on the contrary, are even more active in your care plan when you sign on to hospice and palliative care. There is a team of doctors, nurses, nursing aides, social worker, chaplain, therapy, a music therapist, and a whole team, a multidisciplinary team gets involved in your care. And their sole focus is to help you manage your symptoms. So it's not where you go when people have given up on you. So that's definitely a stigma and a misconception that's very prevalent in our community. Another thing that we often hear is that hospice gave morphine to Uncle Ron and that killed him. I can't tell you how many times I have heard that when I have made home visits to see my patients on hospice, or when I round at inpatient units at Christiana Hospital or at Wilmington Hospital. Yes, we do use morphine for pain relief, for shortness of breath. We do use other medications for pain relief, shortness of breath, agitation, restlessness, which are some of the common symptoms that we see at the very near end of life. So we do use those medications for those symptom relief, but that's not to indicate that it was the morphine that caused the patient to pass away. Ultimately, the patient passes away from the advanced illness and the toll that the illness has taken on the patient's body. Morphine is just used to help with that symptom management. Morphine can be used in a varying capacity. It comes in liquid, it comes in tablets, it comes in IV form, it comes in patches. We use it when we feel like we need it to manage the symptoms. It is very effective and really helps that sometimes the terminal restlessness and anxiety that we see. Another misconception that we hear is that hospice stopped all of Aunt Susie's important medications, like her Lipitor, her cholesterol medication that she was taking, her blood thinners, and all of the other medications. And while this is not entirely inaccurate, I would like to offer a perspective, an explanation for why some of those medications get taken off. So to give you an example, when we see a patient that is elderly and frail and has an advanced illness, again, end-stage CHF, COPD, in this case, cancer, and we look at the cholesterol-lowering medication, like Lipitor, and I only use Lipitor because that's the most commonly used cholesterol-lowering medication, but it applies to all that class of medications. You know, the way a cholesterol-lowering medication would work is it will lower your serum cholesterol level, and then in turn reduce the plaque that forms in your coronary arteries. As you can imagine, it takes a very long time for plaque to form and then for that to give you a heart attack. When we are looking at someone who's elderly, who's very frail, the benefit of a cholesterol-lowering medication at that junction in time is very low. And when you pair that with the side effects of this cholesterol-lowering medication, like muscle aches, side effects on the liver, interactions with the other medication, when we weigh the risks and the benefits, we feel that the risks outweigh the benefits, which is when we recommend that we take people off on those medications that are no longer providing comfort, that are and could be maybe possibly harmful and interact with some of the other medication. And same thing with blood thinners. We have frail and elderly patients, and if they're not frail or if they're young but suffering from advanced cancer, they're at high risk of falls. They have muscle pain, they have unsteady gait. To have them on a blood thinner would increase their chances of falling and having a adverse outcome, like maybe a brain hemorrhage or bleeding in the joints. So just want to talk a little bit about that. Again, every patient's care plan is tailored and individualized. So the team looks at the patient's medications and then make an informed decision with the patient and the family member as to what medications at this point in time are beneficial and should be continued versus what medications are harmful and should be discontinued. Next slide, please.
Well,
Go ahead,
Dr.
Dan. Yes,
Virani, if I could just add a few comments there.
please.
Those two complaints that you mentioned, my hospice team hears those all day long. Anybody here not hear about Uncle Ron who got started on morphine and died from it? Yeah, all day long we hear that. The problem is they have cause and effect reversed. So what I'll usually do is say to people, oh, well, why did they start Uncle Ron on that? Well, he was in terrible pain and he couldn't breathe. Okay, that's why they did that. And I bet it helped him with that, didn't it? Oh, yes, he died quietly and peacefully. So, well, that was our goal. Uncle Ron died from his disease, not from the morphine. The morphine helped him go peacefully so he could spend more time with you at the end. As far as Aunt Susie's Lipitor, that's probably the biggest barrier to hospice. And when you think about it, no wonder people wonder about that. Aunt Susie's been on Lipitor for 20 years, and we've been pushing her to take it every morning and never forget. And Aunt Susie based her life on taking that pill every morning. And now you're saying not to do it anymore. So I always will try to emphasize to people that, yes, Aunt Susie was right to take that for 20 years. And that Lipitor did its job, but it won't help Aunt Susie now. Lipitor, you're trying to prevent a heart attack in 5 to 10 years. And the fact that we put Aunt Susie on hospice means that that's not an issue. If Aunt Susie's going to be here in 5 to 10 years, yeah, she should take her Lipitor and shouldn't be on hospice. So we hear these complaints all day, and that's what's behind them. I can understand why people get upset about those issues. So it's an educational issue for us.
Absolutely.
Right.
No. Yeah, no, thanks, Dan. And, to your point, I think the more we can talk to our patients and our family members, to relieve their concerns, I think the better job that we will be able to do as a team, because at the end of the day, we have a shared goal to make Aunt Susie and Uncle Ron comfortable. So, we talked about stigmas and misconceptions as to we feel like, hospice is where you go to die. They're going to stop all your regular medications and you're just going to be put in a corner, waiting to die. But in reality, it's actually the exact opposite. It's not passive at all. It's very active care. So like I mentioned earlier, we have a team, a very passionate team that gets involved when a patient signs on to hospice. And we're actively not only managing symptoms, but providing care in home, whether you need equipment, whether you need a medication delivery, whether you've developed a sore and now you need, dressing changes, or, whether you have other needs that come up from every now and then, like a family member that's not able to care for you and you need respite, or, a caregiver that's struggling and you need a chaplain support. So it's actually very active care, mainly focused on anticipating what's coming down the pike so that we can stay prepared for it. Our focus is on symptom management, quality of life, caregiver support, and personalized individual care plan that provide in-home services. So if you have family members that are able-bodied and that are able to help you, that are able to stay home with you and help you manage your symptoms, we will train the caregivers on how to provide that care. We will train the caregivers on how to administer medications, how to do dressing changes. But on the other hand, if you don't have that support in home, that's fine too. We will be your support. We will have a team of trained professionals that come into your house and provide you with the care that you need. And there's tons of literature and lots of evidence in so many medical journals that show that the quality of life actually improves when patients sign on hospice. And sometimes they even live a little bit longer than they would have otherwise lived had they not been admitted to hospice. And the reasons for that is better symptom management, taking away of some of those medications that were causing side effects, and a more focus on compassionate, comfort-driven, and holistic care. Why do they sometimes live longer? Because they're in less pain, which causes less stress, or they have been taken off of medications which were interacting, or the fact that they feel relieved that their family is not in this alone, that there is an entire team of trained professionals that is going to help the family to deal with this. And even with planning after the patient has passed on is a big stress reliever. And sometimes we see that when that stress is taken away, when that very important burden is taken off the plate of patient and caregivers, we see that the quality of life improves, and the mental health and the physical health also improves. Next slide, please.
Okay. Well, when is it time for hospice? It's time for hospice when curative treatments are not available. That happens all the time, of course. Often our cancer patients have been in curative treatment for months and nothing else is going to work realistically. But with any disease, when there aren't any more curative treatments that can reasonably be expected to work, when the quality of life has become the focus of care, after all, that's what we do. Our overriding goal is to help every patient make the best they can out of every day they have left. And when the prognosis is considered to be approximately 6 months. That's the definition of hospice care in the American healthcare system. Every country has its own. Next slide.
So how to get on hospice? We get that question a lot. Well, how do I get Uncle Ron or Aunt Susie on hospice? So primary care physician, if you're seeing your primary care physician in the office and they're having a conversation with you about hospice, they can make a referral. A family member can pick up the phone and say, you know, I have this loved one that is suffering from such and such. Would they be eligible for hospice? The family member can make a referral. The patient themselves can call and say, can I be evaluated? A social worker in the primary care physician's office or in a hospital setting can help with that. If you, let's say, if you have a home health agency and a home health nurse coming into your house for whatever reason, they can pick up the phone and make a referral. Anybody can make a referral by calling a hospice provider. Luckily, for the size of our state, we are blessed to have many hospice providers to choose from within our state. So, you know, word of mouth, if you have a friend that has had a positive experience with a provider, you can pick that provider and choose that provider and give them a call. Or if you've seen the billboards or your primary care physician had a positive experience with a particular hospice company, then they can recommend that and they can make that referral. Once that phone call comes in from anybody, then an eligibility check is performed by the hospice provider. So they check the insurance, they check the diagnosis and the clinical specifics. And now, while this is a formality, that doesn't mean that if someone doesn't have an insurance, that they're not eligible for hospice. Hospice companies will take on patients even without insurance. That is never a barrier. When we say diagnosis, there are certain diagnoses that we consider end stage. So like advanced cancer, end stage heart failure, advanced dementia, advanced COPD, but these are just some of the diagnoses. There are many, many diagnoses that can fit into that definition of hospice eligible. And then obviously clinical specifics of the case. What is the disease burden? What is the functional and physical limitation from that disease? What are other medical comorbid conditions, and so on and so forth. So when we look at a referral, when we look at a consult, we look at everything holistically and comprehensively to make that determination. Is this person eligible and good to get on hospice services? Sometimes a home visit can take place to determine appropriateness for hospice. So a doctor can come out to your house to see if you're appropriate. A nurse can come out to your house. A social worker can come out to your house. So sometimes we do make a home visit. We don't always have to make a home visit, but sometimes we do. And then if a patient is deemed eligible, then a certificate of terminal illness will need to be signed by 2 physicians. And once that's done, hospice can start. And those two physicians can be the primary care physician, the oncologist, the orthopedic surgeon, the neurosurgeon, and the other physician could be the hospice physician themselves. So just some technicalities on how to get on hospice. Next slide, please.
So what services does hospice provide? Hospice will provide all the medications for symptoms that are associated with the hospice diagnosis. All treatments associated with it. Not every treatment is a medication. For instance, hospices will often cover physical therapy if it's associated with the terminal diagnosis. Visits on a regular basis by the nurse, nursing assistant, chaplain, social worker, the doctor is needed, volunteers, the music therapist, the whole team. Next slide, please.
Okay, so let's talk a little bit about eligibility criteria. CMS or any other, if you know, whether you're Medicare, Medicaid, or a private insurance company, there are certain eligibility criteria that need to be satisfied for someone to get on hospice. So these are diagnosis specific. So for example, if the terminal diagnosis is cancer, then there are specific criteria to that diagnosis. If the terminal diagnosis is advanced dementia, then there are specific criteria related to that diagnosis as to, you know, how advanced is the dementia, what can the patient do for themselves, and so on and so forth. Since today we're talking about cancer, the cancer-specific eligibility criteria for hospice would be disease with distant metastasis at presentation. What do we mean by that? Meaning the cancer started in the breast, and now it has spread to liver, or to lung, or to brain, or something along those lines. Or progression from an earlier stage to metastatic disease by treatment. So what do we mean by that? So the cancer started in the breast, and we started the treatment right away, and we're doing the treatment as prescribed, but the cancer still continues to progress and continues to spread. So now we've gone from an earlier stage to a stage where it has spread. That is an eligibility criteria for a cancer diagnosis. Sometimes when the disease burden is too much and the treatment offers very little hope of being curative and carries a lot of side effects. We all know chemotherapy is very hard to take because of the side effects. So sometimes we will have patients that make an informed decision that I don't want any more treatment for my cancer because I know that it's not going to help, it's not going to prolong my life, and it's going to give me side effects that I don't wish to suffer through. And so I decline further disease-directed therapy for my cancer. And when that determination has been made, when that decision has been reached, then that also becomes one of the eligibility criteria for hospice. Next slide, please.
Well, hospice covers all aspects of treatments and medications for a patient's terminal diagnosis. Hospice is a separately funded federal program for Medicare. It has been since 1974. Sadly, I'm old enough to remember when it started. Not every country has that. But the United States has a pretty good hospice system based loosely on the British model, although there are differences. The United Kingdom and Britain has long been the world's leader on hospice care. Most private insurances provide similar coverage, although they do not have to. In contrast, palliative care is funded through the general medical care system, through Medicare, through private insurance, and there's no distinction made between palliative care and any other type of medical care. So hospice is a separately funded program, and because of that, we can provide a lot more care than can be provided under palliative care. And you'll see that difference throughout the healthcare system. Next slide. How long can you be on hospice care? Because patients worry, Oh, you know what? I really like this hospice team, but if I live past 6 months, they'll cut me off and I don't get to see anybody. And that is not true. Hospice can be used as long as the prognosis is still appropriate. So somebody could have been on hospice for 9 months, but if I, as the doctor and my team, determine that today the prognosis is still 6 months or less, I'm at a hospice meeting right now, and we did this several times this morning. If we make that determination, we can recertify the patient and keep the patient on hospice. So it's not a hard cutoff at 6 months. It never has been, but that's been an urban legend. Sometimes, though, we get to the point where hospice care is not appropriate anymore. People who come on to hospice for certain diseases like congestive heart failure, coronary artery disease, not usually cancer, COPD, will often live longer than the 6 months. And after 6 months, maybe they don't look so terminal anymore. The whole team is coming in to see them. The nurse comes by and lays out their medication for the week, so they actually take the stuff. The chaplain, the nursing assistant come. I go by, the music therapist goes by, and they're not so lonely anymore either. And after 6 months, they look pretty good. Well, those can't stay on hospice because their prognosis is considerably longer than the 6 months. We try to make that a positive thing for them. Do you suppose the patients are usually glad that hospice is going to quit coming? No. But we do term it graduation. So, you're healthy enough, you can graduate from hospice. Isn't that great news? It means you're going to live longer than the 6 month thing that we brought you on with. It's hard to make them happy about this because they're very attached to the team. But what we do is we stay in touch with them and we get them back on the hospice care as soon as it becomes appropriate again. And it will, because none of these diagnoses are curable. Nobody gets cured from coronary artery disease. Nobody gets cured from COPD. They plateau for a while. But in my early years in hospice, I had a gentleman who was on my service for COPD who improved so much. We graduated him, even took a picture of him flipping the tassel on the cap we got him. He lived 13 months out in the community before he had to come back on hospice. 13 months is a big chunk of anybody's life. And that was a gift we gave to him. We got him in good enough shape that he could live without us for 13 months. I felt good about that one. Next slide. So let's talk again about the difference between hospice care and palliative care and when each might be appropriate. So let's take the example of rheumatoid arthritis. Very painful disease. Some of you in the audience might have it, and it's often a reason for palliative care. Patients need things like joint replacements. They have restriction of mobility and movement, incapacity, but it's not generally a disease with a short prognosis. And you can expect pretty long-term survival. The one exception being if the rheumatoid arthritis is severe in the lungs, and it can be, it's not restricted to joints. But except in that case, you can expect your patients with rheumatoid arthritis to live a long time, but in severe pain and with severe debility. Perfect case for palliative care and not for hospice. Let's look at amyotrophic lateral sclerosis, ALS. If I could pick one way not to die, this is the way I would pick not to die. However, nobody gives you that choice. And ALS is a really good reason to bring somebody on hospice. And we will try to get them on as soon as we can. The prognosis is short, even when the disease isn't so advanced. Patients need a whole team because this disease will overwhelm anybody's family and friends. The family and friends need extensive help, no matter where the patient is, and the prognosis is a matter of months. ALS is the perfect disease for hospice in a way that rheumatoid arthritis is not. And I think those two diseases are examples of what is most appropriate, one for palliative care, one for hospice. Next slide. When you're not sure if a patient should be in hospice versus palliative care, just ask. Any of our hospices will send somebody out to the home to do an evaluation. The disease sometimes isn't easy, but hospice can evaluate your case and give you an opinion, and you decide from there.